I am Dr. Mithun, a reader from Department of Orthodontics, Yenepoya Dental College, Mangalore, Karnataka. The topic for today's discussion is Introduction to M.Ortho. M.Ortho is an exam which is conducted as a board exam from the different royal colleges. As the words are telling, when in Rome, do as the Romans do. That means when you are writing an exam which is oriented towards an exam from an abroad university, you will have to concentrate and try to appear as them. So what is M.Ortho? It's an exam which assesses a candidate's core knowledge and competence in the field of orthodontics at a level expected as a specialist practitioner. So this exam is the one which demonstrates a high level of expertise in planning and carrying out orthodontic treatment. What is the purpose of this exam? The purpose of this exam is to determine whether the candidates have reached a level of knowledge and competency which will enable them to function as a specialist in orthodontics. Now coming to any examination, you should understand from an examiner's viewpoint. What do they like? They like a candidate who is well prepared, who has a clear answer to any question, who can communicate clearly and then wait for the next question. And sometimes the way you dress also makes a lot of difference. What they don't like is a poorly prepared candidate who has a negative body language, candidate that interrupts or who is hostile. Now I am going to be discussing about two Royal College exams, that is a bicollegiate exam. One is by the Royal College of Surgeons of England and other one is by the Royal College of Physicians and Surgeons of Glasgow. They have joined together to form one bicollegiate exam, and the other exam is the Royal College of Surgeons of Edinburgh. Now as per the location in India at this point of time, you have two locations in which you can write these exams. That is physical, how you can write these exams. The Glasgow exam is conducted right now in Sri Balaji Dental College and Hospital, and the Royal College Surgeons of Edinburgh, it is at Savita Dental College and Hospitals. Now the exam pattern is slightly different for both of these exams. Okay, the bicollegiate exam right now has a 12 short answer question, the writing part, that is mostly an online based exam. 4 unseen cases with 15 minutes with records and 15 minutes viva examination for each cases, where they will assess you on your information, how you can assimilate the information, how you plan it and application of the knowledge, and how do you communicate it across. 2 sessions of communication which are unseen cases with 10 minutes each with their records and 10 minutes for examination for each. And the last one is the 3 presented cases, written up and submitted. Now something interesting, if you can see here, it is the 3 presented cases which sets it different from your Royal College of Edinburgh cases. Okay, because you don't have to present your own 3 cases in Edinburgh. So if you have are looking out for an exam which doesn't ask you to give any of your cases, then Royal College of Edinburgh would be the exam for you. Next one is on the Royal College of Edinburgh. What are the examination patterns? The written part will have 180 short based answer questions. Second one is the diagnostic examination on 4 case records and the mechanics examination on 4 case records, and the communication examination on 4 scenarios, that is the objective, it is the OSCE. So this is the application form of the Edinburgh program. Okay, as you can see here, you will have to attest your photograph and write all your details. Okay, and take signature from also from your HOD or the clinical in charge, whoever was there at that point of time. What are the general guidance? Who is eligible to set the Part 2 exam? Anybody who has finished 3 years of course of any competitive any board which gives an MDS recognition will be allowed into this exam. Where and when will the examination be done? See, at this point of time it is held at few areas. Okay, based on different years different places can always change. You always have to go to the website, as I will be telling in the next few slides. When can I register? Ideally, it is the registration link will be opened approximately around 3 to 4 months before the exam. You can apply it at least around, they will also give you the end date of the exam. You have already sat for M.Ortho part 2 previously and failed certain parts. Can I give the exemption from the components I have already passed? Yes. You will be given exemption from those parts, but the fees that you will have to pay will be the same. What is the examination fee? Here it is written as 1750. I will talk about it at a later slide because it keeps on changing. When do I need to submit the examination fee? Ideally, after your registration, whether you are eligible or not will be conducted. There will be a survey done by the Royal College, and then they will tell you to do the payment. Ideally, around 1 month prior to the exam. Entrance requirements. As clearly mentioned here, you should have completed 24 months of full-time or equivalent part training in orthodontics. So after 2 years, you become ideally eligible, but the examination will be conducted especially for the part 2 will be conducted after 3 years that you have attended the equivalent, like in India it is the MDS exam. Application for admission to the examination. Right now there are 2 ways of doing it. One is the online method and then is a physical method. Physical method, you will have to, after you have done the online registration, you will have to take a printout of it and you will have to send them physically in Edinburgh. In Glasgow you can send it via mail. This is the Royal College of England, that is the Glasgow the format. Here also you can see that you will have to attest your photographs, name, age, as well as you will have to take sign from whoever was your HOD at that point of time. Now coming to the Glasgow exam, the written part. Now I will just talk about the written part. In the Glasgow online written examination, you can see that there are 12 questions which will have sub questions. The time which will be given to you is 120 questions. Okay, approximately in one short answered question there will be sub questions. So what is the change which has happened in Glasgow is the part 1, which was of an MCQ and an SAQ, has been temporarily withdrawn. Okay, so this has happened since you can check that there was a legislation which told that the part 1 will be exempted from now on for all the candidates. Now location for the written exam, as you can see here, there are multiple centers. One is in Bangalore, Kolkata, Delhi, Mumbai. These are all the written online examination which are the centers in India. Whereas if you go out of India, you will get other centers also. You can choose whichever center you want to give your online exam. Now coming to the fee structure of a Glasgow exam, the whole fee is 1,800 euros, and for a Royal College of Edinburgh, the written part is 300 euros, as well as for the entire part 1 and part 2 of Edinburgh, it is 2,200. So what are the websites? You can just take a screenshot of this and go to this website to find out about Edinburgh, and in this site RCSED to find out about Glasgow. So in the exam pattern for a written, as I told you, first we will talk about Edinburgh. The books which have to be read, one is the Cockburn, it is a handbook of orthodontics by Cockburn. Next one is the Laura Mitchell and the postgraduate notes in orthodontics. It is also called as the Bristol notes. Now here the meaning of short best answer is all of this, it is basically an MCQ, but all of this can be an answer. So what you will have to understand is which is the best answer is what they are looking out for. One of the criteria for this is they will be classifying it based on 2 things, that is in part A and part B. Okay, part A will have 90 questions and part B also will have 90 questions. So one of such examples, I am just giving you some of the examples. This 10-year-old boy attended for the assessment and there are various options. As well as removal of the upper left deciduous incisor tooth, what is the most appropriate plan for the management of this patient? See, all of this can be an answer, but creation of space followed by removal of the supernumerary teeth and immediate bond and traction of the upper left central incisor tooth is more apt looking at the age of the patient. The age of the patient is 10 years. If it was less than 9 years, the other method, that is, you will open up the supernumerary teeth, extract the deciduous and wait for some time. If it was below 9 years, since the age is more than 10 years, then this becomes a logical answer. A 25-year-old female patient came to you with a paid care provider on a wheelchair. She cannot move or talk, but she can use an electronic device to communicate what she wants to say. Her care provider says that she is excited to straighten her teeth to obtain consent. It is best that you. As you can see, the answer here is arrange for her to use her electronic device to consent and ask any questions on treatment. So this is more about the consent, ethics. Those are the kind of questions you will be getting here. Syndrome. The immediate management of a newborn with a Pierre-Robin syndrome could include, the ideal thing here is nasopharyngeal intubation. As you can see, nasopharyngeal intubation should be the first thing because the airway is compromised in such patients. So as these patients are born, you will have to make sure that they can breathe properly. So nasopharyngeal intubation becomes a way more important concern than a palatal repair or a palatal obturator or a hearing aid device. Next question is on a patient that is bonded up with fixed appliance 3 days ago, is calling saying that she is having a poor sensitivity reaction to the appliance. The most proper management is, as you can see here, this is a hypersensitivity question. Okay. The options which are given, okay, are all the correct answers only, but which is the best one is what you will have to choose. In the UK, if there is any problem, everything has to be referred back to your general practitioner. So as a result of it, reassure her and send her to GP for patch test becomes the major, becomes a more appropriate answer here. Remove the arch wire and send her for a dermatologist for a patch test might have been a better answer, but looking at the scenario, reassure her, send her for a GP for a patch testing might be one of the answers. A 12-year-old patient whom you are treating for 9 months now, you are using upper and lower fixed appliances with extraction of 4 premolars. You started space closure 2 months ago. Now you have spotted some decalcification. After you warned his father and the patient, you should. Now this is about the patient confidentiality and how she appears with your accepts for your treatment, maintaining the oral hygiene. You should understand that this is one of the major causes for decalcification of the tooth, caries of the tooth which happens. So ideally you should be sending it back to take a photograph and return him to the dental hygienist for scaling and polishing might be the better answer. Best method of localization of an impacted canine, which is better? CBCT, obviously CBCT will be the best one, then followed by a horizontal or a vertical parallax. Now the question comes whether horizontal is better or vertical is better. According to Armstrong, the best article which tells the horizontal is better than the vertical parallax. So CBCT, then horizontal, then vertical might be a better option. Next one, a 15-year-old boy was diagnosed with a class 2 div 2 malocclusion on a skeletal class 2 base. Upper eye 3 is impacted without any labial or palatal bulge. Which less invasive and more valid radiographic technique would you assess the position of the impacted canine? As the question is less invasive, that means the radiation dose should be very less and more valid. So ideally the less dose of radiation is in periapical radiograph. So by taking 2 periapical radiographs, you can easily identify whether it is in buccal or in the palatal. Now we have finished the written part of the Edinburgh. Now let's go to the written part of the Glasgow that you can see here. Okay. Now these are the topics in which surrounds the topic which surrounds all the questions from this section, that is the index, incidence, genes, cleft lip and palate, supernumerary teeth. ICP, RCP is nothing but your centric relation and centric occlusion, alginate, GIC, orthodontic bias, trauma, synchondrosis, impacted incisors, impacted canine, hypodontia, STHG, that is selective tooth agenesis, MIH, also called as molar incisor hypomineralization, space management, 2 development stages, eruption dates, symmetrical or asymmetric open bites, tooth movement, types of crowding, bone, stress strain graft, superimposition, relapse, white spot lesion, root resorption, friction, headgear, and Cochrane reviews. I'll just run through few of the things which are very important. You can just take a screenshot of this. This is the incidence chart which is taken from various authors. Okay, this is of the supernumerary teeth based on the deciduous permanent and based on the types of supernumerary teeth. Next is the indices. Who has found this indices is usually the normal question which is asked. Goslon, what is it called? It is called the Great Ormond Street, London and Oslo, given by Mars in the year 1987. Gold yardstick, given in 1991. SCAN, standardized continuum of aesthetic need, that's Evans and Shaw. Now these people have a very nice tendency to look at indexes, because most of the cases who are treated based on the IOTN, whether they will be getting the treatment done in a easy method, that is with IOTN. If the complexity is more, they will get a free treatment in NHC, that is their way of insurance, how the insurance work. It will be basically based on that. So that would be for that reason we should know the IOTN very thoroughly. PAR, it is to assess ourselves whether we are doing correct treatment. ICON, index of complexity, outcome and need. And IOFTN is something new which was found out in 2014 by Ireland. They are also assessing the disadvantage of IOTN, as well as they are telling about the IOFTN. What are the functional things like respiration or jaw movement, gummy smile, which was not taken into account in IOTN. Now you can take a screenshot of this. These are all the genes which are responsible for all the syndromes which are given in Coburn as well as in Bristol notes. Now coming to some of the questions which are there, okay, they will usually give you a radiographic image and ask you what are the impacted canines. Okay, how you should just answer according to what you feel is correct. Okay, don't write as a sentence, but be crisp. What is asked, just answer to that. Who originally described it? It was given by Clark in 1910. According to Armstrong, which is better? As we have already told, horizontal is better and vertical is 68%. What percentage of upper permanent canines are impacted? This is the incidence what we already looked up. Next question is the list the proposed etiological theories. You can see the theories of impacted canines there. What is the incident of root resorption diagnosed by 2D? Please provide a reference. Now you can check here, they are actually asking for a reference. That means if you have checked your incidence and know the reference, then you can write it across. What is the incident of root resorption diagnosed with 3D imaging? Give a reference for the same. As you can see, we have given the answer is there in the red. Next important question what they like asking is the stress strain graph, where people have to talk about where they can usually ask questions regarding the range, material for aligning properties and material for space closure. This can be some of the question. Now what is range? It is the amount of deflection that a wire can achieve within the proportional or elastic limit. Okay, if you can see here, this is the range in the stress strain curve. You can see that here, that is the range. Okay, now they can ask formability, they can ask strain, they can ask spring back, they can ask what is proportional limit, yield strength, arbitrary point and a fracture point. What are the methods for aligning properties? For tooth alignment, what are the properties which are required? It should have large spring back, low stiffness, high stored energy, biocompatible and has low surface friction. And ICP, RCP, as I told you, ICP it is intercuspal position and RCP is retruded cuspal position. As you can see here, they have written ICP or centric occlusion. Next question is identify the chart. If you know this, you just have to concentrate on the chart and see what is written in the chart. As you can see here, they would have written this thing. So it is a PAR chart. Inference of the star in the chart. I will get back to this. You can see here this section how they have classified it. If you can see here, it starts from 0 and it is going up. That indicates that it is not good improvement. The middle is improved. This is the section which is greatly improved. Okay, what are the three sections? As you can see here, greatly improved, improved and words are no difference. Fine. This is the IOTN. One important factor of IOTN is there are two components. One is the aesthetic component and another is the dental component. Here this is the aesthetic component, what you can see here, the 10 charts which are there, okay, and these are the 5 gradings, okay, where first one is no treatment, little treatment, borderline need of treatment. Grade 4 and grade 5 are the things which requires your treatment for sure, and these are the ones which are usually indicated for treatment by them. Index of orthodontic treatment is the dental health component can be done with the ruler like this, okay. This can be in your one of the stations also, this can be kept, and they can ask you regarding the how to use this, okay. So you should be knowing how to use this across. As you can see here, this is for the jet. As you can see, it will go in 4, grade 4 of the dental health component. Another component is something called as a MOrtho in IOTN. What happens in IOTN is if there is a overjet, if there is a displacement, a patient can have 2 or 3 of this. Then which will you choose? Which will you name this malocclusion as? Then the rule of MOrtho will appear. That means if there is a missing tooth, you will always rate that patient based on the missing teeth. If there is overjet, next is the overjet. If the patient doesn't have any missing tooth and has got a large overjet, and you have to take the overjet into consideration, then is your crossbite, then the displacement, and then the overbite. So what is the take home message from this section? Answer to the point. Keep a check on time. Please don't try to manipulate your surroundings, because most of these are online based exam and they will be monitoring you. Have a steady internet connectivity if you are writing it from the comfort of your home. The Glasgow exam can be written from your home setting also, whereas your Edinburgh exam are specifically meant to be in certain centers. Next is a part B, the clinical examination of Edinburgh. Okay. Here, as I told you before, that there will be a component 1 and a component 2. Component 1 will be a structured oral examination consisting of 8 minutes 30 seconds, and 4 of the stations are diagnostic unseen cases related to the treatment planning and patient care. Now, limitation to the number of attempts, candidates will be permitted to a maximum of 6 attempts at part A and a maximum of 4 attempts at part B. Now, coming to the other thing, that is the presented cases. Now, as you can see here, you don't have any presented cases in Edinburgh, but there is a presented cases in Glasgow. That's what sets them apart. Submission of case records, okay. It has to be personally treated by the candidates. The 3 cases must have had the majority of treatment completed by the candidate. 2 cases of them will be selected by the examiners, and the duration of the part of this examination will be 30 minutes. Candidates failing the examination but passing the treated case section will be exempted from this section. Clinical case records must be submitted electronically with all the personal identifiers, both of the patient candidate removed. As a part of clinical records, either hand traced or digitally traced lateral ceph can be required. As a part of clinical record, either the study models or digitally printed study models, copies of digital models, scans of study models or photograph of the study models will be accepted. Clinical case record should be accompanied by a signed statement from the accredited supervisor confirming that the candidate's substantial involvement in the treatment. Wherever possible, cases should be complete but may be presented prior to completion where they are extenuating circumstances. So, according to the guidelines, what you will have to have is, in a loose leaf file, you should have lateral skull tracing, recommended size is also mentioned. Record should include a full diagnosis and treatment plan of the case. Photographic would be better, okay, color photo would be better. Full face, profile and other relevant views can also be taken. Radiographs, usually they believe in the concept of minimal radiation, so make it a point that you have taken minimum radiation according to the guidelines. Lateral skull tracing, which have to be there pre and post or end of the treatment lateral ceph. Radiograph of the copies of radiograph, though necessary to diagnose, radiograph should if possible be placed in a plastic envelope. Models, anterior view, left and right view, upper and occlusal view if you are taking the photographs. The patient and name should not be disclosed anywhere. What is the take home message from this section? Take a printed copy of your case. So most of the cases you will have to submit online. Okay. Now in the center which is in India, they expect you to take your cases file. Okay. Defend your diagnosis and treatment plan, and ideally don't argue with your examiner. What happens is you might be having a different viewpoint. There is no point arguing with the examiners at that point of time. They are here to judge you based on what they have been asked, by the guidelines. They are asking you certain question, it is because of the guidelines which are there. Next section is the communication section. If you see, communications section is seen in both of them, that is there in Edinburgh as well as in Glasgow. If you see, they will give you 10 minutes with the records, 10 minutes examination for each. Assimilation of information, treatment planning, application of knowledge, patient-relative communication. If you can see here, for each scenario, you will be given clear instruction to be explained to the stimulated patient or parent. Okay? You should be able to explain clearly the procedure or the process to define the treatment plan and demonstrate an evidence base for your explanation. Now, communication skills are basically about how well you can follow the domains, okay, of communication. Whether you are humane, that is whether you are able to communicate with the patient at an emotional level, whether you are patient centric, whether you are professional in doing what you are doing, and communication and explaining and imparting the knowledge. Whether you are able to listen, it is not only about preaching, it is also about listening, organization, and at the end of it, you will have to provide a summary for all your thing and inspire confidence in the patient. And the best part about this section is the marks will be given by one part of the marks also will be given by the candidate who is going to be there in your communication station. That means one of the participant or one of the actor can be chosen and he will be giving marks to you. So obviously, even if they are irritated, even if they are rude, you have to go to a level that you will make sure that you communicate whatever you want, irrespective of the how the patient is talking to you in a rude way or even in a not so in a nice way. The communication cases, if you check these leaflets which are available in the BOS site, it will be very helpful. There are free downloads of the patient information chart. That is the website link which is there. This is the website link. Okay. Typical scenario, parent or a patient asking for impossible or inappropriate treatment. So ideally you are not supposed to accept to that. You should always tell that this what you are thinking is wrong, and what is the correct thing you will have to tell to the patient. Difference between what is available on NHS or privately, this is exactly why I was telling you that IOTN is very much required. Difference of opinion or having a second opinion. If the patient is coming to you for a second opinion, never talk bad about the first opinion. Okay, you can always tell that this can be one of the other alternatives. When things have gone wrong, always accept the mistake, but also try to calm the patient. That would be the way to go. Questioning a treatment plan or methods of treatment. Yes, the patients will have to be informed about what are the treatment plans which can be done for that patient and how it can be done. So, one of the communication cases where what they can ask you is, this is one of the the communication case which had actually come. 14-year-old female, class 2 skeletal, camouflage with extraction, poor oral hygiene since 2 years into treatment, warning of discontinuation if there is poor oral hygiene. Disappointment, white spot lesion is noticed. And they have told that you have to convince for debonding, sequence of events, what will happen after that, if good oral hygiene is maintained, how to treat the patient. So these are the clinical scenarios which can be there. Convince for debonding, yes, you will have to talk to the mother. Ideally it will be a female 14-year-old, so mother will be accompanying. You will not talk directly to the patient, you will be talking to their parents. So then you will look out for how will you manage with all the sequence of events. If we remove it, then what will happen? You have seen a white spot lesion, so you will give it enough time for it to remineralize. During that time you will give certain fluoridator or specialized toothpaste, mouthwashes. Then you, if required, you will fill it, and if the oral hygiene is maintained correctly, after certain part of time you can still continue or restart the treatment. Second scenario is a 19-year-old male, class 3 skeletal, camouflage with all 4 extraction, debonded 5 months ago. Patient reported after 5 months with broken retainer and has not been wearing them. Currently, incisors with reduced overbite and edge to edge relation. Likely cause of relapse. Ideally, the patient is not wearing it, so that can be one of the reason. Or they have specifically told it's a class 3 skeletal and you have done camouflage, so it can be because of the late mandibular growth, which might be very prevalent in a class 3. And how to treat this? Yes, then you will have to check on the malocclusion, how much amount of crowding is there, does it require an orthodontic treatment completely, or you can just do 1 arch or a 2 arch, how you want to go ahead. The following case is not covered under our NHS. Yes, ideally these kind of things are not covered under NHS. Before it would have been covered under NHS. It was a skeletal class 3, there were a lot of issues. But now this might not be, because only one retainer is broken, reduced incisor has overbite which has been reduced. Okay, so this will not be coming under NHS. So what is the take home message for communication station? Just be courteous, be humble, listen to what the patient wants to tell you, and don't use any dental terms. So like white spot lesion, you can tell discoloration. Okay, remember to always introduce yourself to the parent. Body language should always be open, lean forward and listening. You are acting, pretend to show pictures or an x-ray or model if this help explain the problem. Remember local protocol for complaints. Remember to apologize if appropriate. Ask or offer second opinion and complaints procedure. Try if possible to close the situation with a summary and agreement from the patient. Next is the unseen cases. There are 4 unseen cases, both in Edinburgh, as you can see here, as well as in Glasgow. Each case 15 minutes with records, 15 minutes with examiner. Most of the time examiners will take 7 minutes for diagnosis and 7 minutes for your treatment planning. Examiner will take you through the records in sequence, aspects of importance for diagnosis, soft tissue, skeletal pattern, malocclusion, explore your understanding of key parts of the diagnosis, dental health, etiology and IOTM. Questions on treatment planning, problem list in the hierarchical order, aims and objectives of the treatment plan, the treatment sequence, retention and stability and prognosis. This is the hierarchy of the treatment plan questions which will come no matter what the case is. For unseen cases, the best book to read is Clinical Cases in Orthodontics by Coburn and Pedre Fleming. The Coburn, the handbook, as well as Laura Mitchell are a must read. Candidates will be marked on the following 3 skills. One is the clinical and radiological assessment. Second is aims, objectives and treatment planning and rationale. And the third one is the anchorage management and mechanics to achieve the plan. So you will have to make sure that all these 3 are recorded in the patient. Now, what are the clinical scenarios which can come? Impacted canine, impacted premolars, MIH, molar incisor hypoplasia, peg-shaped lateral, class 2 div 2s, supernumerary teeth, cleft lip and palate. All these are usually the kind of cases which come. So we are going to the last section, that is the mechanics case section. So from 2022 it was told that the cases which will have to be submitted will be removed, and they are going to give a new section that is called as we discussed here, mechanics section. Now what happens in a mechanics section is you will be given a case which is at a mid phase. Okay, they will show you the pre-treatment, they will show you the present stage case, where at what condition it is. It is like taking a case which has been transferred from somewhere, and you have to justify what the treatment, what was done, was it correct? If not, at this point of time, how will you try to treat this patient? They will be judging you based on the description of the current features, progress and mechanics utilized to date, anchorage management and rationale, whether your anchorage is good or wrong, and objectives, whether they have been able to achieve the objectives and will you be able to achieve the objectives when you are doing the treatment planning, as well as the retention. Usually the questions on mechanics comment on the appropriate treatment, challenges with treatment plan, alternative treatment options, method of action of appliance or the technique used, what would you do next, alternative solution for success. If you see here, this is the link for the mechanics. There is a template which is given for the mechanics examination. One thing you will have to understand is there are certain guidelines given by the Royal College, okay, which stands as a guideline for you to do certain cases. Okay. Now this is the site for the guidelines. Okay, can just take a screenshot of that. Now here are all the clinical guidelines which are available by Sullivan, that is the Royal College of Surgeons clinical guidance for dental erosion. I know it might not be important for us, but on the safer side, just know these things. Jamil Hussain for palatally ectopic maxillary canine, Yakub 2016 unerupted maxillary central incisor, 2014 by Coburn for extraction of first permanent molar in children, Durham, that is TMD and orofacial pain, 2003 compensating and balancing extraction in primary dentition, McNamara Bruden, RME in upper and Schwartz in the lower for moderate crowding. Now these are the clinical guidelines which are given by the Royal College of Surgeons of Clinical Guidelines. So most of your questions in and around will be around this, and they will be targeting you based on those guidelines what are given. So at the end of it all, how are they going to judge you? That is, 4 is good, that is an impressive candidate who is well informed, fairly critical, good decision making skills and justifies the approaches well. 3, he is pass, reassuringly sound rather than impressive, able to justify only some approaches well, but most appear sensible. Second and first is the place which is considered as fail and poor. So you should always try to aim at 4. 3 is okay. I mean, ideally you should be looking to achieve 4 in all the situations. So this is the section what I had during my time. They on the part 1, which exam you don't have right now, that part 1 you will just get a thing that you have cleared or not. And in the second one, that is in this, they will give you your marks. Like here, the written mark is 4 out of 4, case presentation submission. So the another good part about this is even while you are submitting it, you get a credit score. Case presentation viva will have 4 marks. SRC 1 and 2, it will have 4, that means 2 per cases, in which I have lost 1 mark here. SRC 3 and 4 is 4. Communication session is 4. So out of 24, I had achieved 23 to clear the M.Ortho exams. So at the end of it, you will get a certificate which is a bi-college certificate because it is done from both the colleges, that is from a Glasgow as from the England. So how I would like to continue or conclude it is, M.Ortho is an exam which is dedicated for people who want to uplift themselves and want to have an higher degree from what they have at this point of time. Proper guidance and orientation towards M.Ortho exams is what was the aim of this whole presentation. If you have any more doubts on this aspect, you can feel free to contact me on this email ID or contact me personally at this email at this mobile number. Thank you everyone.